Thank you very much for asking me to do this session, Peter. I have two roles with regard to clinical audit, really. One is that I'm a consultant radiologist, and therefore it's my responsibility to make sure that my patients receive the right test at the right time and that it's going to contribute to their diagnosis. And I'm also Medical Director for Professional Practice for the Royal College of Radiologists in the UK, where we have a very well-defined audit programme. And so I'm going to try and share that with you today so that you can get some ideas for how you might facilitate audit within your own local organisations. So how do we define clinical audit? It's very interesting because some years ago I went to a conference on audit in Tampere in Finland, which was very much based on audit, the external audit of radiation protection practices. Whereas clinical audit, the definition of clinical audit is somewhat wider than that. And Don Obedian has defined it as the systematic, critical analysis of the quality of medical or clinical care, including the procedures used for diagnosis and treatment, the use of resources, and the resulting outcome and quality of life for the patient. And really, that's what we're all about in radiology. Why do we do it? Well, in any department, you've got all these things. You've got service quality, investigative protocols, clinical risk management, etc., etc. And they tell us how well we're doing. Clinical audit provides the evidence for how well we're doing. It indicates if we need to change our practices, and it highlights the resources that we might need to do that. And of course, that then informs clinical governance and quality improvement. In the UK, we have set up within our college, the Royal College of Radiologists, the Clinical Radiology Audit Committee, which is known as CRAC for short. And this leads clinical audit in radiology in the UK, and its remit is to promote and develop the use of audit in radiology settings. We have a chair who is a clinical radiologist, and we have 6 radiologist members as well as a junior representative. We have an audit officer who is one of the staff members of the faculty of the college, who helps with administration purposes, and we have an administrator who keeps us on track. And then also the president and college officers attend. What does it do? Well, we have 5 or 6 main areas where CRAC does work, and this is nationally within the UK. And I'm going to talk about all of these things. First, we have Audit Live, which I'm going to describe in detail in a moment. We have an audit lead radiologist in each trust, so there is a network of audit across the UK which feeds back to the college, and we feed out to those audit leads. We conduct national audits. We circulate an audit newsletter. We have an audit forum once a year, which is like a workshop for the audit leads. And we also run a poster competition. And I'm going to tell you a little bit about all of these things in this presentation. Audit Live, in 1995, the Royal College established the Audit Committee, so we were quite well ahead of the game with regard to audit. And in 1996, we produced these 2 booklets, one in 1996 and one in 2000. And some of you may be familiar with these 2 booklets because for many years, they were the audit Bibles for clinical radiologists in the UK. And they both contained recipes, what I call recipes. They were like a cookbook, and they took a topic and went through it and showed you how you could audit against that topic. But following on from that, we then developed Audit Live, which we consider the jewel in the crown of audit in the UK. And this is a web-based tool for facilitating local audit. There is a bank of over 140 interactive, downloadable audit recipes which you can adapt for your local needs. There is a focus on dose reduction and, obviously, best practice. Users are able to submit their own templates for consideration of publication, and it's a way of sharing best practice with regard to radiation dose across the UK. Anybody can access this. Anybody in the room can access this. You log on to the Royal College of Radiology website, which is www.rcr.ac.uk. But if you just put Radiology UK into Google, you'll get there. And that comes up with the home page of the website. You want to click here on clinical radiology, which takes you to the clinical radiology pages. This is where you get. And you'll see that here there's a whole column devoted to audit and research with what's going on currently within audit in the Royal College of Radiologists, current audit projects, and what you want is this, Audit Live 100 plus recipes. You can click on that, and that takes you to the landing page of Audit Live. So when you get to the landing page, you see a list here of recently published audit templates. So these are the new ones that are just coming in. So that helps you if you want to look for something new. Oh, look, there's me. So within this page, you've got how to use the tool. You can use a search. You can either search by keyword. If you know a topic you want to look at, you can search by keyword, or you can choose on a list here of topics. So you can either type your keyword in there, or you can choose from this list. And I thought we would look at patient focus here. So we're going to, just to give you a quick example, look at how we do this with regard to patient focus. So you click on patient focus, or you could, as I say, you can use the search button. And if we click on patient focus, we get a list of things that are being classified behind the scenes as being important for patient focus. So you can see there's all sorts of things there with particular regard to dose. And if we're going to look at today at an audit of lumbar spine radiography for low back pain, this is an audit tool to look at the appropriateness of lumbar spine radiography, because lumbar spine radiography contributes a significant amount of cumulative dose within the UK, or it did. And here you get the background of the audit, you know, the thing that we're really doing by reducing the number of radiographs performed inappropriately for non-specific low back pain. We can facilitate the way patients get to the important points in the care pathway and avoid unnecessary radiation. This then gives you the recipe itself when you've gone down the bit, scrolled down the page a little bit, and it gives you the background to guidance that we have in the UK on lumbar spine radiographs, and it shows you the target and how you can assess local practice, how you can collect data items and the numbers. And this is a bit further down the page. It'll give you resources, and more importantly here, it gives you hyperlinks to various publications on low back pain. So, for example, in the UK, we have the National Institute for Clinical Excellence, which evaluates evidence. It produces evidence-based guidelines for what we should be doing, and I can click on there, and I get straight to the nice website, and I can actually either read the complete summary or the full guideline documents if I want to know about the background to the audit. We can save the audit pro forma when we've done it, so that we can actually fill it in and keep a record of what we've done. And this is just an example of what the audit pro forma looks like. This may be useful for within your own department, or if you're having an external inspection. If you've got these pro formas saved, you can say, well, we've looked at this as part of our workup for this external inspection, and we are happy that we are reducing the dose here. And we can also fill in a form if we have to send to our hospital's audit office. In the UK, we have to undergo audits which go to our audit office. So that's how you use one of the keyword searches, and I'm just going to skip through. You can also use a wildcard, which is a % sign. I'll just skip through this quickly. So if you type in your % sign under the keyword search, that brings up a list of all of the audits in there. So you can just scroll through the list, and we might want to choose something here just to see. We'll look at complications in vascular radiology very quickly, just because I want to show you something else that some of these recipes have, which is you can have highlighted in blue an appendix in some areas, and that actually then gives you some extra information. So this is an appendix which they use in vascular radiology for the agreed recommended upper limits of complications. So there's a lot built in behind the scenes within this tool. So it's been up and running now for 5 years and continues to be very well utilised with about 400 to 1,000 hits per month. And it's continually updated with about 10 new audits published 3 times a year, and also the content is updated. So if you have a recipe that's been in there for about 3 years, they're all looked at on a cyclical 3-yearly programme so that they are updated. For example, we started off with quite a lot of references to keeping films, and of course none of us use films anymore, so those have all been replaced. So the next thing we do is we have an audit lead radiologist in each trust, and they are the liaison between the Royal College of Radiologists and their department. They facilitate their own departmental audit meetings, and they coordinate local input into the national audits that we run. And they help to influence national policy and strategy. We also run national audits, and this is usually on a topical issue. Data is collected via electronic submission and anonymised, and the results are then presented to the audit leads at the annual audit forum. This is just a list of some of the things we've looked at in the last few years. And some of you may be familiar with the liver biopsy audit we did, which was published in Radiology. We had 2 papers out of that. We've done quite a lot of things. This year, we're looking at the National Audit of Paediatric Radiology, again, because that's very important with regard to dose. But I'm just going to discuss with you a little bit more about the audit we did a little while ago on the National Audit of Appropriate Imaging. Or should it be appropriate requesting, really, but appropriate imaging. Why did we choose to do this? Well, I think this graph is very telling. This is the per caput annual collective dose in millisieverts across some European countries. And you can see that Germany is up here, Belgium, Switzerland, Iceland, France, and the Scandinavian countries, Denmark, Finland, Lithuania, and the UK are much lower. Now, why is that? It's interesting, isn't it? The Euratom directive stated very clearly that we must have written protocols for every type of standard radiological practice, and that we should have guidelines and recommendations concerning referral criteria for medical exposure, and that we should all be doing clinical audits in accordance with national procedures. So we chose this one to have a look at. The European Commission has also produced guidelines on clinical audit for medical radiology practice, which you can access at their website. So this is a hot topic. It won't go away. Hannu Jarvanen, who's one of the leading lights in this kind of audit program, he works out of Finland, and he has said justification, so you have to justify that radiation dose, is among the priorities of an audit program. And general conclusions were that we must audit compliance with guidelines, because this can be a simple and effective tool for improving referral patterns, thereby reducing the burden of dose for the population. So we in the UK have imaging referral guidelines which are available nationally, and our standards for this audit were that 100% of justifying practitioners should have access to the image referral guidelines, 95% of GP requests for CT or MRI should be vetted individually or through an agreed protocol, and 90% of GP requested CT and MRI examinations are compliant when we perform them with guidelines or local protocols. So this was our national audit. The survey went out to all of the audit leads. They submitted their data electronically. These were just the indicators. So having got that data in, we wanted to know what were the percentage of sites within a hospital where justifying practitioners have availability of the guidelines for vetting, etc., etc. So the appropriateness categories, which have been adapted from iRefer, which is our electronic guidelines, is the investigation indicated? So is it an unnecessary repeat examination? Has it been done already? Do I really need to do it again? Do I actually need this investigation? Is it going to affect patient management? Investigating too early, for example, in chronic back pain. Has this patient just got chronic back pain, or do I need to do this now, or can I wait a few weeks and try conservative management first? Is the investigation indicated as the first or best choice by the guidelines for this particular condition? So is it the best investigation? And has the problem been explained properly on the referral form, that I know that this is the right investigation for this patient? These were our responses. You'll see that we got an overall response rate of 81%, which is really very good for a national audit. And it was quite interesting. If we look at the first standard, about a third of respondents didn't have ready access to the guidelines, which should be available nationally. And there was only a 67 to 60% availability level. And that was well below the standard of 95%. And the respondents estimated that about half of hospital clinicians and GPs probably have the guidelines available, even though they are supposed to be nationally available. And although this was outside the scope of this audit, this level of availability was very low. So in other words, the GPs weren't asking for the right things because they didn't know, because they didn't have access to the guidelines, the right things to ask for. And 50% of our respondents used print copy locally. There was difficulty with availability due to web access, and we now have agreement for NHS distribution throughout England so that GPs will be able to access the guidelines. And one of the things that the recent discussion from the Bonn Summit on radiation has stressed is that referral guidelines and decision management pathways really should be built into the requesting software. So that's something that we're working on. So the vetting and justification of the requests met and exceeded the standards. So that means when we get a request in, we as radiologists or our radiographers working to agreed protocols are very good at vetting those requests and making sure that they are appropriate. And, you know, the compliance is excellent, and I think that's because we do this meticulously, and there is appropriate vetting, and we do amend and return requests in favour of alternate diagnoses. So that was pretty good. And it's interesting that 12% of CT requests and 9% of MRI requests were either amended or returned. And the appropriateness was pretty good. That also met the standards. So that meant when we did the investigation, following the vetting procedure, yes, it was appropriate. So the take-home points from this is that imaging referral guidance, although we have written it and it's supposed to be nationally available, only 2/3 of radiology departments admitted to be able to access it. But we now have this network called N3 in the National Health Service in the UK, so this should address this issue. We do, in the UK, meticulously vet and justify these particular examinations which were studied in this audit, and the appropriateness of the imaging when it's carried out was correct. So, you know, the three key things here are awareness, appropriateness, audit. So good practices for the future. We really need time vetting within our very busy work plans. We can use local pathways for imaging common clinical problems, and we need to educate at all levels and with all clinicians. So our requesters really need to know what they're asking for, what's the burden of radiation. And as I've already said, there should be consideration for computer-based clinical decision support systems. And we need to work with our GPs for improvement. So we fed back these results to individual departments via the audit forum, the newsletter, and we published the results in radiology journals. Just very briefly to finish, I'm going to just show you the other things that we do. We publish a clinical audit newsletter. That's a way of communicating with all members and fellows of the Royal College of Radiologists. It feeds back to all on the results of national audit, and we circulate it usually via the e-bulletins, and it's available on the website. We run the audit forum, as I've said earlier, which is held annually. It's multidisciplinary, and it's a forum for presentation and discussion of the results of national audit. And we also encourage presentations from the winners of our audit poster competition, who are usually junior radiologists. And it's a very good way of getting them aware of the importance of looking at what they're doing and why they're doing it. The poster competition is national, as I've said before, and it's held at annual scientific meetings. Trainees are encouraged to submit audit, and unlike here, at the moment, all of our posters are actually displayed, so people can go around and look at them. And we have first and second prizes. We subsequently display the posters on the website, and as I've said before, the participants are encouraged to present at the audit forum. Again, on the RCR website, if any of you want to look at it, there is advice on how you should write a good abstract with regard to audit. There is advice on poster production, and you can look at previous poster winners so that you can see what they've done. This is one of the winners, and it's that good old topic again, lumbar spine radiography, so I'm glad to see that this particular person is using Audit Live to get an idea about this. You can see they clearly state the standard, and they've clearly formulated an action plan because they've done the audit, they've worked out what they need to change, and their action plan is that they must consider GP rapid access MRI rather than doing plain films. So why are we doing all this? Well, in 2007, the European Commission established the project to review the status of implementation of clinical audit for the assessment of radiological practice in member states. They prepared guidance on clinical audit, and there was an international workshop on practical implementation of clinical audit for medical exposure in Tampere in Finland in September 2008. So it's been a slow movement since 2008 when this all started off. Audit is here to stay, and I'll take you back to this first slide. How well are we doing? Audit provides the evidence, it indicates the changes needed, and it highlights the resources that we need. And again, it comes down to the bottom line, clinical governance. Are we doing the right test on the right patient responsibly and keeping dose down, and quality improvement? So key messages. Its main purpose is to improve the practice of clinicians and teams. It interlinks with standards, professional development, and in the UK, revalidation. You'll only get the benefits when you engage your clinicians. If they're continuing to ask for inappropriate investigations, you've got to feed back to them. And it requires leadership by us in the profession. And our experience is that audit succeeds when it's locally owned and structured, it's relevant, multi-professional, and integrated with a wider quality improvement programme. And we believe that our model in the UK encourages all of the above. Thank you. And don't forget to log on to the website.